Okay, hello everyone, and welcome to today's webinar titled ISO 10993 Updates in Practice from E&L Testing Challenges to ISO 10993 2025 revisions. Hosted by Biopharma Webinars and presented today by Elizabeth James, biocompatibility expert at Nelson Labs. So first of all, hello Elizabeth, welcome. Thank you for joining me today.
Hello.
Hello, it's a pleasure to have you here, and thank you. And joining Elizabeth, we also have Walter Bisons, who is E&L Project Manager at Nelson Labs. So, Walter, hello and welcome. Thank you for joining me today. It's a pleasure to have you as well.
Hello.
Welcome. So my name is Marcus. I'll be today's moderator. And before we begin, I would just like to inform our audience we will be having a live question and answer session after both presentations today. So please feel free to send in as many questions as you like via the questions button found directly below your webinar screen. And please also include the name of the speaker you would like me to ask your question to. Okay, we look forward to answering your questions later. So now please allow me to introduce our first presenter. And Elizabeth James holds a master's degree in industrial engineering in chemistry and joined Nelson Labs in 2019. Elizabeth is a subject matter expert in extractables and leachables testing for medical devices, and she has years of experience in developing extractables and leachable study setups and writing the subsequent reports. In 2023, she evolved in her role to become part of the Nelson Labs Advisory Services team as a biocompatibility expert. Elizabeth uses her extensive knowledge in extractables and leachables to write biocompatibility assessments that are targeted for regulatory submissions all over the world. Elizabeth is an active member of several international organizations, International Organization for Standardization, ISO committees related to the biological evaluation of medical devices. So with that, I'd now like to hand over to our presenter today and welcome Elizabeth.
Thank you, Marcus. So I'll start the presentation by saying again that yes, I am a part of ISO committees and specifically the working group 1 within the technical committee 194. So that's the committee and the working group responsible for the development of ISO 10993-1. So that being said, my presentation will be about the updates of ISO 10993-1. So this update happened in November. It's quite possible that much of what I'll present today is already familiar to you. But as you may also be aware, the changes between ISO 10993-1 2018 and 2025, those are really quite significant. So even if there has been a lot of discussions about these updates, I think we can never talk about them enough. And so it's really good to continue to inform yourself, to follow presentations, to attend to webinars, any discussions that you could have, because that way you can make sure that you have that you're really understanding every time a little bit better the extent of those changes. So here is the agenda for this presentation. We will first go into the alignment with ISO 49701. Then we'll jump into the concept of reasonably foreseeable misuse. We'll continue with bioaccumulation, life cycle evaluation, contact duration, device categorization and biological effects, material-mediated pyrogenicity, and biological equivalence. So those are the topics that I want to cover today, because I believe that those are really the biggest changes or the most impactful ones. But of course, there are a lot more than just that. So yeah, just be aware that those are the main things, but of course there are other little changes here and there as well. So the first topic is the alignment with ISO 4971. So ISO 4971 is about risk assessment for medical devices. Now, I do want to say that the whole topic of risk is the same as the one that we have been having with previous versions of ISO 103-1. So we're not changing or having a new discussion. It's just that we are including more precise terminology and we are aligning with the industry in terms of risk assessments. So in terms of where to start with this alignment, I think it's a good thing to start with definitions. So a hazard is a source of biological harm relevant to intended use. The harm is the injury to human from an adverse biological effect of a medical device, and the risk is a combination of probability of occurrence and the severity of that harm. Now, what I do find really important to consider also in our biological evaluation documents from now on is to really understand the link between hazards and harms. So to go from a hazard to a harm, we need a sequence of events and we need that to lead to a hazardous situation. Now, it's important to note that the sequence of events can be led from intended and foreseeable misuse. Now, to illustrate that with a kind of generic example, I have this slide right here, and I want to thank my colleague Audrey for this example because it's really generic, but it helps understanding the whole concept here. The idea is, of course, sharks are a hazard. They are a potential source of harm. But depending of the situation in which you are in, there is a way that no harm will be done to you. Of course, if you're swimming in a pool, then you're not going to encounter any shark, so no harm done. But if you're swimming in the open ocean, then there's more chances for you to meet a shark. And then, of course, there's also different harm possibilities because you could just get one hand bitten off. But if the shark finds you very tasty, then the other possibility, the other outcome of death is also possible. So that's a kind of generic example to illustrate really the link between hazard and harm. But if we go back a little bit to the medical device world and the ISO 103-1, then what we can say is that the ISO 103-1 is also including examples of hazardous situations and of hazards that lead to harm or do not lead to harm. And so I've listed them here on this slide. So for the hazards that lead to harm, we have the presence of released harmful additives. And it's interesting here to really note the word released because it means that it's a fact and that something can reach out to the patient. We see also that there are presence of hazardous particles or potentially toxic compounds. Now, there are also hazards that do not lead to harm. We have the hazards that are contained in a non-degradable material. And then very, very similarly, we have the toxic compounds that are hermetically sealed inside the device. And in both those situations, what is really important to understand is that there is no hazard because there is no harm, because the hazard cannot reach the patient in the fact that there is no patient exposure. Also in alignment with ISO 4971, the concept of reasonably foreseeable misuse was now formally introduced in ISO 103-1. And that concept has for impact that you have to consider misuse in the device categorization. So it's not something that you can think about later on. It's really something that you need to consider from the get-go, because device categorization is really one of the first things that you do in your biological evaluations. So what's really the definition of the term? It's a use of a product or system in a way not intended by the manufacturer, but which can result from readily predictable human behavior. It can be intentional or unintentional, and there are additional factors to consider within ISO 24971. Now, I do want to go back a little bit to the words readily predictable human behavior, because I think it's very important to understand those words, in the sense that I had a discussion with a biocompatibility expert from a sponsor, so another company, that was telling me, yes, I'm manufacturing a hearing aid, and I want to consider the reasonably foreseeable misuse in my biological evaluation plan. But when I looked at one of the misuse that happened recently, is that one patient decided to swallow a hearing aid. Is that something that I need to take into account in my biological evaluations? And of course, this is not something that you want to take into account. That's not readily predictable human behavior. Now, in examples, there are some examples provided in ISO 10003-1, and I will go through them to illustrate a little bit what those imply afterwards. So there is the example of reusing a single-use device. In that case, it means that the single-use device is perhaps reprocessed. So perhaps we need to look into cleaning validations, reprocessing validations. There's also the potential for patients to be exposed to a longer duration than expected to the device. So that's all little things that we need to consider then in the evaluations. There's also very similarly the example of using a device longer than prescribed. In that case, if your device was limited or prolonged, do you need to up classify your contact duration, so to prolonged or long term even? There's also the example of incorrect application. And to illustrate that, I can talk of an example that I had with a discussion that I had with another sponsor that manufactures wound dressings. And she wanted from now on to consider that the adhesive of the wound dressing could also come in contact with the patient or the wounds more, because normally in wound dressings, only the wound pads comes in contact with the wounds, and the adhesive surrounds the wound pads. But if the user is the one applying the wound dressing, there is a possibility that they will not apply correctly the device, and therefore that the adhesive could come in contact with the wound. There's also the example of using adult devices on pediatric populations. Pediatric populations, they are sensitive populations. They do need developmental toxicity as one of their additional biological effect for consideration. So that means that probably your adult device wasn't evaluated for that biological effect. And if you know that your device is also used on pediatric populations, then you need to consider it as well. In terms of responsibility, the manufacturer is the one that is responsible for the reasonably foreseeable misuse concept. The reason for that is that the manufacturer is really the person that has the best knowledge about how the device is used concretely or misused. Whereas biocompatibility assessors, they know how to do the evaluations, the biological evaluations, but they might not know how your device can be misused. So it's really important from now on in for future and biological evaluations using ISO 103-1 2025. It's really important to have a very good discussion between between the manufacturer and the biocompatibility assessor. And in practice, it means that in most of the cases, the biocompatibility assessor will now need an access to the risk management file of the manufacturer so that they can really align between the concepts of the risk management file and apply those into the biological evaluation documents. Another information that was added or broadened in scope, I would say, in ISO 103-1 2025 is the lifecycle evaluation. So the definition of lifecycle is a series of all phases in the life of a medical device, from the initial conception to final decommissioning and disposal. So within that, there are some things that are unchanged. So we know that the selection of materials do need to always consider the fitness for use first, and that's not changing as compared to version 2018. And also that the potential for materials to change during transport, storage, or use, that's also something that is unchanged as compared to the previous version of the standard. What is really new or something that is more formalized into the documents is the fact that your biological evaluation plans and reports are not a one-time type of documents. So you are not writing them and then you're done with them and you can never look at them anymore. So that's not the idea. Now the idea is really to review them periodically, and certainly with post-market surveillance data, that becomes a new set of data points that you can feed your BP and BER with it, meaning that if there are findings in your post-market surveillance data, then that can perhaps have additional identified risks that need to be fed in your BP and your BER. The concept of bioaccumulation is a completely new concept. And basically the idea is that if you have a substance that is known to bioaccumulate and that is present in your device and can reach the patient, then you need to adjust the contact duration of your device. So for example, if we take a very famous example of a substance known to bioaccumulate, the PFAS are a family of substances that are known for that. And if your device is made out of PFAS, then and is considered, for example, limited or prolonged, then you will need to adjust to a longer contact duration, so long term. Because the idea is that the contact, the repeated contact with the device is not allowing for the metabolization of the substance. There is not enough time for that between each exposure. And so the substance is keeping building up into your body, which means that the contact duration is not limited or prolonged anymore, but can go up to long term. So that is if you know from the get-go that you have a substance that is known to bioaccumulate. But if during the evaluation later on you identify that there is a substance that is bioaccumulative, then you need to adjust the contact duration even later on. So if you have reached your BER stage and you have now discovered that there is one of the substances within your device that is known to bioaccumulate, then you need to retroactively do the adjustment. Speaking or continuing the topic about contact duration, what the device contact duration, there is a very big change in there, but there are also things that remain unchanged. So we have still, as previously, we have the three device contact types or duration types. We have the limited contacting device that contacts a patient for less than 24 hours, the prolonged one that contacts a patient for 24 hours to 30 days. And then we have the long-term contacting devices that contact a patient for more than 30 days. We have a slight change with the brief tissue contact name. Previously, it was called transitory, and it's now changed to brief tissue contact. Now, really, the meat of the change is where you do your contact duration calculation. So basically, any contact now is a daily contact. So you count the days from the first to final contact, and that's your contact duration. And you include that includes also replaced devices. So if your device contacts a patient 5 minutes one day and then 5 minutes a second day, then that's not 10 minutes of contact, that's actually 2 days of contact. We have also a new concept, which is the intermittent contact, and that's a contact for which we have 24 hours between each contact. In that situation, you add the number of contact days from first to last use. So if I use an example, if I say that a device is used every 2 days for a 14-day period, that's a total period of use of 7 days. And as I mentioned previously, the concepts of bioaccumulation and reasonably foreseeable misuse also need to be considered in your device contact duration. So if I come up with examples and see how devices were looked at, so determined in terms of contact duration calculations previously and now, and I take the example of a inhaler. So previously, with the version of 2018, an inhaler that was used 30 seconds per use, 4 times a day for 7 days. In total, we would have added up all of those seconds, which meant that in total, the device would be in contact with the patient for 840 seconds or 14 minutes, which means that is below 24 hours, and that is therefore a limited contacting device. If we follow the guidance or the recommendation of ISO 103-1 2025, the time of exposure doesn't matter. It's a daily contact that matters, and there are 7 days of contact, which is above 24 hours of contact, and that means that the device is now considered as prolonged contacting. Another example of an intermittent catheter, and that catheter is used on 3 different days for 6 hours each time over a period of 5 days. So that's a total of 18 hours of contact, which means that that is below 24 hours, and the device is therefore considered as limited contacting. Whereas now, using the version 2025, again, what matters is the daily contact. There are 3 days of contact, which means that the device is now considered prolonged. Another change is the body contact type and the biological effects for considerations. So this is table A1 that was in ISO 103-1 2018. This table was used to look at the nature of body contact, contact duration, and then get an understanding of what biological endpoints were to be considered for your device. The same principle is applicable for the 2025 version, but the presentation is slightly different. It's actually not one table anymore, it's four tables. what I did on this slide in order to get an overview of all of those tables is that I collated them into one big table. But just know that within the standard, there are really four different tables. So the way it works is the same. We have the contact types, we have the duration, so ABC referring to limited, prolonged, or long-term contacting devices. And then we have the biological effects for consideration. Those are now named biological effects and no longer biological endpoints. In terms of contact types, we see that we have still the family of intact skin contacting devices, the mucosal membranes, and then we see a kind of combination of two families of the previous families of 2018. The breached and compromised surfaces is now also combined with the internal tissues, so the externally communicating devices contacting bone tissue dentin. And we have also a fourth category that is now devices contacting blood or circulating blood. I will go through all of the highlighted changes in yellow in the next slides. So the first thing that we can note is that systemic toxicity is no longer separated into durations. So it's really just called systemic toxicity. And there are no references to acute, subacute, subchronic, and chronic into those tables. The reason for that is that we know that the duration of body contact is an important determinant for systemic toxicity, and that more extensive evaluation is required as the duration of body contact increases. But that is not meant to be included in ISO 10003-1, but it's something that can be found back into ISO 10003-11, which is a guideline that is really specific for systemic toxicity evaluation. We can also see that implantation is no longer called out into the table because it was rebranded as local effects after tissue contact. The reason for that is that there was a kind of confusion in the industry that devices that were not implants did not need this effect or did not need to consider this effect. But actually, they do need to look at it. And let me take an example. If we take the example of vaginal rings, those rings, they are not implanted in the body of patients, but they remain inside the body of the patient for a long time. And so we really want to look into what are the local effects after that contact between the tissue and the device. And so it's not really, it's not an implant, but we do need to look into those local effects. For the mucosal membrane family, the things that the biological effects that are added are genotoxicity that is added when prolonged systemic exposure occurs, and carcinogenicity is added when long-term systemic exposure occurs. And by the way, for intact skin contacting devices, there we're still considering cytotoxicity, sensitization, and irritation, so nothing is changing there. For the family of breached, compromised, and internal tissue, I mentioned it. It's really the combination of two previous families from the 2018 documents. And in terms of consideration, we are adding genotoxicity again when there is prolonged systemic exposure that occurs. We have now one big family of devices that contact blood. It's one category. And if you want to understand which biological effects apply to your to the hemocompatibility test that you need to look at for your device, you really need to look into ISO 10003-4 to really see also a difference of considerations between indirect and versus direct contact with blood for each of those devices that do contact blood. Material-mediated pyrogenicity, or MMP. You may have noticed that MMP was removed from the table that I just presented, so the tables of biological effects for consideration. Now, MMP still needs to be considered for devices that have a history of causing a pyrogenic response, or for devices that contain materials with an unknown pyrogenic potential. Now, for a lot and many devices, a justification is now possible by showing that your final device does not present a significant risk for MMP, and that you have manufacturing controls to prevent pyrogenic contamination. I've included here the article that is also referenced into ISO 10931 2025 from Lindsay Borton and Kelly Coleman, which is really demonstrated that materials-mediated pyrogens are really very rare. And so by calling out to this article into your biological evaluation plans, for many devices, there's a way to justify out of MMP now. So biological equivalence, that concept is not really new, but it's more formally described now in ISO 10931 2025. So the idea behind it is that if you manufacture two devices, one is already on the market and it's known to be safe, and you're now manufacturing another new device for which you don't have a lot of information on right now. You can use biological equivalence to show that both devices are sufficiently equivalent that you can say that the information on the known safety of the first device is applicable to your new device. And that can really ease your biological evaluation process. Now, in order to do so, you really need to check a lot of boxes, which are to demonstrate that there is chemical equivalence, you need to demonstrate physical equivalence, and you need to demonstrate contact equivalence. And in practice, it means that for chemical equivalence, you need to show that your raw materials, that your manufacturing processes, your processing aids are the same, meaning that practically you really need to be the manufacturer of the two devices that you're trying to compare. Otherwise, you don't have sufficient information to be able to demonstrate that equivalence. Now, I'm nearing the end of the presentation. I just wanted to look back a little bit on what we have been doing until now. So until now, our approach at Nelson Labs has always been to look at biosafety evaluation as a three-step approach. So we first look at a biological evaluation plan where we look at the device, we look at the risks, and based on those risks, we come up with a plan to address them. The second step is really to go into addressing the strategy that was discussed in the BP. So if that is testing and risk assessment, then do so. And then the third step is the writing of a biological evaluation report in which you really come to the conclusion of the biological safety. And I do want to say that even if all of those changes in the standard are impressive, the conversation remains the same. It's just more formal and in a more standardized format. So this is actually my last slide. I have introduced a lot of different concepts, and I know that many of you, if this is the first presentation you're seeing about ISO 10931 or you're really discovering the information, you could be thinking, Okay, that's a lot of new things and not a lot of information on how practically to do things. And I agree with you. So that's true. Um, the ISO 103-1 2025 update, it needed to be published, and it was published in a format that needed additional content. So everybody within the working group was aware of it. This was something that we had discussed in the Paris committee last year, but we could not push back on the publication of the standard. Otherwise, the standard would have needed to wait another 5 years before starting a new process of updating it. And so the standard was published, but everybody acknowledged that we needed additional guidances for the new concepts. And that's why the working group one of technical committee 194, so the working group that's working on ISO 103-1, is not, the work is not done. It's continuing and it's taking the form of 6 projects. Each of those projects will end up in technical specifications and technical reports that will be published in the next years, in the coming years. So there will be one project about risk estimation, one project about bioaccumulation and intermittent contact. There will be a guidance about life cycle evaluations, one about biological equivalence, one about reasonably foreseeable misuse, and then a final one about how to use clinical data within the frame of ISO 103-1. So what I can say is that the goal is to have drafts for the 2 first projects out by summer, so that the working group 1 can have a look at the comments at the ISO level for the meetings in Japan, the ISO meeting in Japan in October. The next 2 projects, so project 3 and 4, the idea is to have drafts at the end of this year or beginning of next year. So we are really working on those, but it will take a little bit of time before they are actually published. So this was my presentation. I want to end it up with an information that we have a website, the Sotora Health Academy website, where you can have access to a lot of content, so presentations, but also white papers, so a lot of different type of contents, and you can register for free to access those. So I thank you for listening to this presentation, and I'll be happy to take questions after Wouter's presentation. And so I give back the word to Marcus.
Okay, thank you very much then, Elizabeth, for your presentation there. And we've had some questions come in already, so thank you to the audience members who've sent in questions so far. We look forward to asking them later in our live Q&A session, and you can still continue to send in questions during our next presentation as well. So now please allow me to introduce our next presenter. And Wouter Bisons received his master's degree in industrial engineering with a specialization in chemistry in 2017 from the University of Leuven. From 2018 to 2021, Wouter worked as a product specialist in Michelin, where he contributed significantly to customer satisfaction. He joined Nelson Labs in 2022 as a scientific project manager, widening his expertise in extractables and leachables for medical devices according to ISO 10993-18, designing study setups and writing comprehensive reports. In 2025, he further expanded his expertise and responsibilities to include combination products and large volume parenterals, reinforcing his role as a multidisciplinary asset within the company. So, with that, please allow me to hand over to our next presenter and welcome Walter.
Thank you very much, Marcus. And I first will try to move the camera because we have gotten a few comments that it's too noisy. So hopefully this is better. So also I wanted today to talk about challenges encountered during ISO 10993-18 ENL testing and also the possible solutions and ways out. So this presentation will, in short, start with just an overview of what ENL testing is. And then also, in short, I'll try to do it in short, but explain a very important aspect for this presentation, which is the analytical evaluation thresholds. And then I will go over sample requirements, extraction solvents, extraction setup, extraction volume, and the ratio, and also then close off with the extraction conditions. So first, as requested by ISO 10993 Part 1, the sponsor has a biological evaluation plan in hand, and this will mention, okay, we need ENL testing according to ISO 10993 Part 18 to address some biological endpoints, such as systemic toxicity, genotoxicity, carcinogenicity, and others. So then, of course, you will come knocking on our door, and then we have the request to do an ENL testing. So in this short example, I will use a pacemaker that is implanted in a patient. So to the right, you will see this, but then to the left, there's a schematic representation. And it's possible that during manufacturing, sterilization, packaging, and so forth, some compounds will be present in or on the device, and these may leach into the patient, which can cause unwanted effects. So in ENL testing, we are interested in determining which compounds, of course, are migrating to the body and at which concentration. For this, we have ISO 10993 Part 18 for medical devices. But as you can see, I also added another document, which is the FDA draft guidance for the industry on chemical analysis for biocompatibility assessment of medical devices. And this will also be referenced sometimes in this presentation. Afterwards, when the ENL testing is done, you will have to do a toxicological risk assessment by a toxicologist to see whether any of those compounds that migrated to the patient might be a health issue. So, but this is according to Part 17, but I will not focus on this one in this presentation. So back to ENL. So what is extractables testing? Extractables testing is testing what can come out of the material, as shown here. And then next up, we have leachable testing. And in leachable testing, you're more going to milder conditions, and you want to see what comes out of the material and into the patient. However, a problem with medical devices, of course, is that the application is within a patient or on a patient, and these conditions are very difficult to simulate in a laboratory. So we are going to call this simulated use conditions, as you cannot perfectly replicate the reality. So leachables or simulated use studies are part of extractables because the conditions are milder. You expect less leachables than extractables. But leachables in this presentation will not be a focus. It was just to explain what the difference is between extractables and leachables. So now to the AET, or the analytical evaluation thresholds. I will try to not go too much into detail, but it is very important to understand what this is for the whole presentation, everything that follows after this. So in ISO 10993 part 18, there is a formula given that shows how to calculate the AT, and it's given on the screen here. The AT is a concept introduced for organic screening methods like GCMS or even LCMS, which are very important part of an ENL study. And those will be used for trace analysis of organic compounds of varying chemical properties. And the AT is used to calculate the level, how low you need to look for these organic compounds, and is expressed in micrograms per milliliter. So if it's not clear at the moment right now, but I hope to clear this up in the next few slides to understand what and why this AT is. So first we see for the AET calculation, you need a DBT or a dose-based threshold, which is the same as a threshold of toxicological concern, the TTC. And this TTC can be found in ISO TS 21726. There's a table in there that will specify the TTC that you can use based on the patient contact duration. So you can see it here in the table below. And just as an example, if you have a very long-term, so over 10 years implant, like the example here, we see a hip implant, it's most likely going to be used over 10 years, then you need to use a TTC or a DBT of 1.5 milligrams per day. But if it's a very short contact, then you can use 120 micrograms per day. Next up is the uncertainty factor. The uncertainty factor is there to account for the analytical uncertainty of the screening methods, because there is an inherent degree of uncertainty that you will have in the found concentrations of these methods. So any other method that is not a screening method or an organic screening method, the AET is not applicable. To calculate this uncertainty factor, we have ISO 10993 part 18 amendment 1. But I will not go into much detail how this is calculated. Just understand that there's a way to calculate this for a laboratory. And then we come to A, B, and C. A and B are based on the extraction setup. A is the number of devices that you will use to generate an extract, and B will then be the volume of this of the extract. Then we have C, and C is the clinical exposure. So how many items will a patient use each day? And this really needs to be the maximum amount. So the worst case of items that a patient can use. Back to A and B. A and B, if you divide A by B, it's also the extraction ratio. It's just another units, because an extraction ratio, and we will see this later in the presentation, will be in squared centimeters per milliliter. Here it's just items per day, per milliliter, but it can be easily transferred to squared centimeters. And one thing that we like to add with this AT calculation is the next D. And the D is mainly added because of a concentration factor, so sample or the extract manipulation after the extract is generated. It's a bit weird that we don't use C, but C was already used by clinical exposure. So we use D, and then we can say, okay, it's the dilution factor, but the dilution factor is the inverse of the concentration factor. So it's 1 divided by the concentration factor. Personally, I don't like this, but you will see in the presentation that a lot of times the D is lower than 1, and this is the reason why. And the reason that we add this is because you will change the AET because you are concentrating an extract. This is also mentioned a bit in the ISO 10993 part 18, where the AET is discussed, that you need to consider all dilutions and concentration steps during your extract processing. Next up, we have an example. So I just used the hip implant, so 1.5 micrograms per day due to the long-term, more than 10 years contact with the patient. And then I just simulate now an extraction, one device that we will use and 50 milliliters that we will add. The clinical exposure is 2 devices maximally used per day for each patient, because you have left and right, a hip that can be replaced. And then as an example, first I use D as 1, meaning no dilution or no concentration is performed. And then the uncertainty factor will be 2. And during this whole presentation, I will try to keep this AET calculation and change some numbers to show what happens. But for this case, you will see, okay, it's 0.0075 micrograms per milliliter. At this moment, of course, this doesn't say anything, but this will hopefully become clearer later. Now to the next line, I have changed only the concentration factor. Instead of 1 or no concentration, I increased it to 20. 1 divided by 20 is 0.05. And we see an increase in the AET, which is good. And why is this good? Well, for any organic screening method, there is a limitation in the instrument and the methodology. It's called the limit of quantification and the limit of detection. These are the limits of the instruments. And if your AET is above that, everything is fine. You are able to reach the AET with your limits, let's say. If, for example, then we are between our LOD and our LOQ, there is starting to become one problem, and that is there is now a gap where you cannot quantify. You're still fine with detecting everything, but quantification starts to fall off and is not guaranteed for everything anymore. And then the next case where you are below the LOD, you have a gap where you should identify compounds and you're not able to. So this is a big problem, and this is a case that should not happen. So hopefully that was a bit clear. And yeah, now let's go to sample requirements. First up, I want to explain a bit how sample requirements are calculated in general. This is done in 4 steps. First, you select the amount of solvents that you want to use, and then you can determine how many extractions you will do. Then we calculate all AETs. We've done one AET calculation now, but I will do it in more detail and explain a bit more on the LOD and the LOQ. And then we will determine all required volumes. And after that, we can apply the extraction ratio to determine the final sample requirement that is needed for a ENL study. So first, we will determine the number of extractions. And you will select a number of solvents. Later in the presentation, we will see which solvents you will select, but let's take this case of 3 solvents. Ultra pure water, which is water for injection, which is not sterilized, so very pure water. Isopropanol and hexane. So these are 3 solvents, but if, for example, you need to do an exhaustivity determination because you need exhaustive extractions, again, later we will see what this is, but you will need to do this for every solvent. And this is a separate extraction. So we already need 3 extractions. And then we need to do still the final extraction. And for the final extraction, okay, we have 3 solvents, but you see I added 1 extra. And this is because I do an extraction in glass and in plastic for ultra pure water. And this is mainly because, a plastic vessel will give contamination to the extract, which is not wanted for organic methods. And that is then used, of course, for element analysis, trace element analysis. Why don't we do this from the glass? Well, glassware has elements that can contribute, like silicone, and you really see this popping up. So you want to then do an extraction in plastic. So you see 3 solvents, and we already need 4 or 7 extractions in total. Now to the calculation of the AET, and I will just do this for one, but we should do this for every single solvent and also for every single technique. But this example will show it for GC. So we have a device with a surface area of 150 square centimeters. This was also the example that I explained earlier. And we will apply an extraction ratio of 3 square centimeters per milliliter, which gives us 50 milliliters per device, indicated in orange. And then we will use a concentration factor of 1, which is a D of 1. And again, we come to this 0.0075 micrograms per milliliter. And this is a problem because this is lower than the LOD of our GC instrument. And the LOD you can see at the bottom left, it's 0.03. So it's lower than that, meaning we have a gap in which we cannot identify any compound. Next up, I have increased the concentration factor to 10, meaning the D is 0.1, and of course it just increases by 10. But we're not yet at LOQ level. Now we're in between both, meaning that quantification for some compounds will not be good. So we will keep going, and now we're at a concentration of 20, and we are above the LOQ, which is fine. But because we need to do a preparation then from 20 milliliters, for example, 20 to 1, we need at least 20 milliliters already for just this technique and this analysis. So now we can determine the required volumes. In case of an exhaustive extraction, we need an exhaustivity determination, as explained in the first part. This will already require a certain amount of samples. And then we have the final extractions. And also for exaggerated extractions, this is very similar. This is mainly based on this concentration factor that we just determined. And with our example, we had 20 milliliters required, but we have an extraction ratio of 3 centimeters squared per milliliter, meaning we already need at least 50 milliliters for one sample. So yeah, we already have 50 milliliters. But as I said, you need to do this for every single technique that will be used and every single solvent. And then one thing that I want to mention as well for exhaustive extractions is that the FDA requires the final exhaustive extraction and the exhaustivity determination to be performed in exactly the same manner, meaning that the amount of volume, solvent volume, and also the amount of items that you will use and the extraction vessel need to be exactly the same. So you need to adapt the final extraction to the exhaustivity determination, or the other way around, depending on what will be needing the most volume and most items. Then we will apply the extraction ratio to determine the sample requirement. So in our example, 50 milliliters, we have our extraction ratio, and then we come to 150 squared centimeters required, which is 1 item per extraction. And then we will need in total 4 or 7 items, depending if it's an exaggerated or an exhaustive extraction. However, for FDA studies, it is required to use, or it is best to at least use 3 items per extraction, because in the FDA draft guidance, it is explained that triplicate extraction may not be necessary if 3 or more devices need to be pulled. This is not exactly the same, but in any case, it's best to use at least 3 items, meaning that we will have 12 or 20 items required, at least. And then to close off the sample requirement, I want to quickly talk about item families. It's preferred to test the largest device in your family. So if you, for example, have some kind of plate and it's in different sizes available, it's best to test the largest one. Alternatively, if it's not possible, you can test a smaller device, but then we have to apply a correction factor. And this is easiest done by increasing the clinical exposure. And then we have this example, 150 square centimeter, which is the largest. If you want to then test an item that is only 100 squared centimeters, then you need to recalculate this and you will come to 3 devices per day. This is mainly to calculate within the 80. It's not really used for anything else. Then we also have very small items. So if the surface area goes down quite a bit, the sample requirement will go up very easily. For example, a glucose monitor, which is a very small needle. It's so small that a very large amount of items would be required. You can try to reduce the volume on that, so increase the extraction ratio, but we'll see later whether that's possible. So now off to the extraction solvents. And ISO 10993 part 18 says to have at least a minimum of 2 extraction solvents of different polarity. In most cases, a polar and a non-polar extraction solvent like water and hexane. However, in most studies, also a semi-polar solvent is added, especially in those cases where you have blood contact. And now here from part 18 as well, there's also a table to show some solvents that are commonly used in ENL studies. But it's mainly important to have compatibility between the solvent and the device. And as you can see, 3 solvents are highlighted. It's water, IPA, and hexane. So it's the 3 most common solvents. For the semi-polar solvent, you can also use ethanol. But if you go to any of these other solvents, sample preparation and also instrument analysis will start to become more difficult because techniques are generally designed around a few solvents, and if you go to a too exotic solvent, it starts to become a headache for the lab. And then there's this excerpt from the FDA draft guidance. And in the FDA draft guidance, it specifies the recommended extraction vehicle or the extraction solvent based on the duration of contact. And as you can see, only for long-term devices, you should add a semi-polar solvent. But again, if there's blood contact, you should really add a semi-polar solvent. Now, sometimes you do not have a compatibility between your solvent and a device. And unfortunately, you can have destructive swelling. And destructive swelling is a problem because the extractable profile that you will see is not representative for any real use. It's too exaggerated. You're breaking down your device, so you will see, and this will obscure a lot of the wanted extractables that you want to see. So this is not representative of. So that's not good. Sometimes you can then start with a feasibility study in which we will look for compatible solvents. So go to another solvent. For example, here to the left, you see this is IPA versus hexane, and the hexane will start to solve quite a bit, also break down the material. As you can see, it's not nice anymore. But we've seen that for similar solvents, hexane, you will go to heptane or isooctane or another one, but you will see very similar behaviors. FDA, as you can see here at the top right, requests to at least evaluate 2 additional alternative solvents. And really what needs to happen is in a feasibility study, do the extractions and take a lot of pictures to show that it's really not a good solvent to test. So what else can you do? Well, as a last resort, maybe if changing a solvent doesn't work, you can lower temperatures, but be very careful with that. Because you really need to argument why you would do this. Going to a lower temperature, you cannot go, of course, below the clinical use temperature, but sometimes you have glass transition temperature of your material that is lower than the temperature that you're using in your extraction, and yeah, in that case, it may be beneficial to go a bit lower. But in all cases, you should be above the clinical use temperature. There's also non-destructive swelling, and non-destructive swelling is fine to continue. It's just the device swells a bit and absorbs some volume, but it does not impact too much of your study. It will not break down the material. It will not throw a lot of unwanted extractables out there, and then it's fine to use. What you will have to do is do a check how much solvent is absorbed. And of course, this means that you will need to test this separately before the rest of your study, meaning that the item requirement goes up. So if solvent absorption is expected, it's best to always do this upfront. Otherwise, you will start to do an exhaustivity or an extraction, for example, and all the volume goes away, and then yeah, you can restart again. Then also the extract can change, not after the extraction, but during the extraction, of course. And this is linked to the previous one where where you're degrading your material, or some extractables that are coming from the device that are easily going into the extract give a turbid extract or change the color of the extract. Sometimes you also see particles or precipitation. And this is not beneficial because you can clog your instruments with that, and then it's a problem. Or you will see it will obscure a lot of the vision in the chromatography. So what can we do there? We can dilute the extracts, but of course, increasing the D factor will reduce the AT. And as you know, with the 3 figures before, your AT will go lower and lower, and perhaps go below the LOQ or LOD of the instrument, and you have a new problem. Another option is to filtrate. The FDA is not a fan of this, but sometimes you have no other choice. If centrifugation doesn't work, you have to filter. But there is a possible loss of extractables, and you can try to solve this by doing some tests to see what can be lost. But let's not go too much into detail there. Because next up, we have the extraction setup. And we have 3 types of setups. The first one is the most used, which is the submersion and shaking incubation. These are just devices where all of the surface of the has patient contact, but also some devices where not all of the surface has patient contact, but the 2 other extraction methods are not possible. The next one is a filling, and then also a shaking incubation. That is where the outside of the device never has patient contact, and then a submersion would be too extreme. So you want to do a filling and shaking incubation. And then the last one is the circulation. You don't need to do shaking because there's a lot of movement of the solvent already, but you want to cover the recipient. So after this is done, you want to cover it with aluminum foil to reduce solvent loss. Otherwise, if you incubate this for a few days at 50 degrees, for example, you will lose a lot of extraction solvent. So that was quick and easy because there's not much you can do there. So now let's get to the volume and the extraction ratio. So we would start at ISO 10993 part 12, and I see it's a bit gone here, but it's the part 12. There's a table in it, and it's the only standard that mentions an extraction ratio. But as you can see, it's just a table that says the extraction ratio to use. And for example, in most cases, most devices that have a thickness larger than 0.5 millimeters can use an extraction ratio of 3 centimeters square per milliliter. But yeah, in any case, this is only a starting point. This is also mentioned in the FDA draft guidance that you can start from part 12, but it's not a rule. You can change it if you argument why you do this. But yeah, the part 12 is for biological evaluation, so it's not too relevant for a chemical characterization, but as I said, it's the only standard that mentions one. So for the extraction ratio, we started part 12, and then we change it either to achieve an AET above the LOQ if it's easily solved like this, or reduce sample manipulations. If you want to reduce the amount of concentration that you can do, you can lower the volume, and lowering the volume means increasing the extraction ratio. So you can play it with it a bit like that. But it's also important that you will submerge your devices. It's always important to keep devices submerged. So it's possible that you will need to increase your volume and thus reduce your extraction ratio. And another option to change the extraction ratio is to add filler materials like glass staves or glass bars. This is to take up the space that the solvent would normally take up, and this it reduces the required volume of the solvent. Now, to show this in the same example, we have the same calculation, and I kept a concentration factor of 10. You see this as 0.1 in green. And we have a total surface area, once again, of 150 centimeters squared per device. If we would use a extraction ratio of 1 squared centimeter per milliliter, we would have 150 milliliters. It's just dividing your total surface area by the extraction ratio. And again, you can see we come to an 80 that's below the LODA once again. That is not good. So let's increase our extraction ratio. And in this case, again, we are in between LOD and LOQ with our AET, and this is the 3 centimeters squared, so the most used. So we want to go a little bit higher until we're above the LOQ, of course. And for example, here we use 6 squared centimeters per milliliter. And this is just to show how the AET can change easily with the extraction ratio. And now to close off, we have the extraction conditions. For the extraction conditions, we have once again ISO 10993 part 18. And in table 2 of this document, it shows that recommended extraction conditions, and it's per patient contact duration. And you can see, okay, from prolonged contacting on, it's recommended to do exhaustive extraction condition. But for limited contact devices, there is this simulated use condition. One problem with this is, so simulated use is where you do a temperature and a time based on the real clinical use. The problem here is that it's not in the FDA draft guidance. Therefore, in most cases, you will do the credible alternative, which is an exaggerated condition. And this is fine for both part 18 and the FDA draft guidance. Now, for an exaggerated condition, once again, what is an exaggerated condition? Well, you exaggerate the temperature and the time that you would be, that the patient could have contact with the device. In part 12, there is this quick, you see this excerpt below, there's quickly shown what could be in extraction conditions, but once again, part 12 is for biological tests, but we can use this, and in January, we use this highlighted one, which is 50 degrees and 72 hours. Mainly the reason is 37 degrees, which is also indicated as too low temperature, and 70 degrees is quite a high temperature already, and is also a short duration, 24 hours. And then, yeah, if you go even further, 121 degrees, that's not good for many used materials. So 50 degrees, 72 hours. For exhaustive extraction, so for prolonged contact and long-term contact, we first need to determine the exhaustivity. And according to part 18, this is a multi-step extraction where the amount of material extracted in a subsequent extraction is less than 10% of that determined in the initial step. This is an interesting formulation, and it's just want to say that you first need to do an extraction experiment where you add the solvent to your device as a first extraction, for example, 50 degrees, 72 hours. We do this, we get an extract, and then we remove that extract, of course, and we add fresh solvent, and we do this again and again and again. And in this example, I did this 4 times. And what you want to check is the amount of material that is in these extracts. At some point, you will go below 10% of the material that was present in the first one. And in this example, it is only at the 4th extract. This is mainly done with NVR, so non-volatile residue. This means that you just place those extracts that we've taken and put them in an oven to evaporate all solvent, and then weigh how much material is left. And this is the NVR. There are some alternatives like TOC. This is total organic carbon, but this is only possible with water. But you can also do chromatography. And there you can use a mass spectrometer detector or even flame ionization detection. But these are very difficult exercises and are also very expensive exercises. And even these methods, both TOC and chromatography, they only look at organic extractables. So that is not necessarily beneficial. Then for the exhaustive extractions, we need to do the exact same what we did with the exhaustivity determination. So now we know the exhaustive point, which was the 4th extract, but we need to do everything again because we lost all our solvent to the NVR determination. So we do this again, and then you analyze each extract separately. However, what you can do as well is pool all these extracts, but the problem then is that you increase the volume, and thus, if everybody listened carefully, we will reduce the AET once again. And pooling is, of course, also quickly discussed in the FDA draft guidance, saying that it's fine as long as you either pool everything or don't pool at all. You cannot do pooling subsets of the extraction. So I think this is my last example of the AET calculation for a GC method. If we do pooling with this first example, we do 2 cycles of 50 milliliters, and that is fine because we then have 100 milliliter. I use the concentration factor of 40 to just be above the LOQ. If we would go to 4 cycles, it's starting to lower already our AET, and then we're really between LOD and LOQ, and then an extreme example is 11 cycles. I hope to never have this. But yeah, if you then have 550 milliliters, and then we're below LOD. So this is a problem. And then in that case, you would have to analyze everything separately. So now to close off the full presentation, just on the exhaustive extractions, you have 3 options. So you refresh the solvent each time separately. This is the sequential extraction, and analyze everything separately, sorry. This is fine because it anticipates the saturation phenomena, but it also allows a very sensitive detection because you're not diluting the extracts with pooling. But this is an expensive approach because you need to do quite a lot of lab work. And then we have the pooling in the middle. This also anticipates the saturation phenomena and is less expensive, but the AET gets lower and lower the more cycles you have. And then the last one, which is not allowed by the FDA, is to not refresh each solvent. It's just a one-step extraction where you, in the example that I've shown, you do 4 times a 72-hour extraction, which is 288 hours. You just add once the solvent and you do a one-step extraction for 288 hours. So to conclude, a medical device extractable study or a chemical characterization is quite straightforward, but issues can quickly arise. and thus an appropriate approach should be selected. And of course, at Nelson Labs, we're for sure we can help you with this because we have a lot of experts. So once again, like Elizabeth, you can register for free with our Sotera Health Academy. And thank you for listening. And now back to you, Marcus.
Okay, thank you very much then, Walter, for your presentation, and to Elizabeth previously with her presentation. So we've got lots of questions to get through, so let's jump straight in. I'm going to bring us back onto cameras. Okay, one moment. Okay, and then this first question is going to go to Elizabeth. Okay, so this question says, where do you expect changes to follow if 14 typical minutes must be considered as if exposed for 7 days? Which kind of devices / development benefits from this increased scrutiny?
Yeah, thank you for this question, because actually that's something that I should have brought up during the presentation. So thank you a lot, Jean, for bringing this up. It's about the example of the inhaler for the steroid treatments, where we do see that for isotonic-1, the 2018 version or the 2025 version, we see that there is a real difference into the categorization of the device depending on how we look at the contact duration exposure. So why why did we go to daily contacts? Actually, that's a question, or how I understand it. The fact for that, or the reason for that, is due to the fact that when we are using a medical device, we really have the contact duration, but actually the effect of that device, of the contact between the patient and the device, is not limited to the time of contact. And so it's not entirely correct to say that if you have a wound dressing, for example, on the skin, that is on the patient, I don't know, for let us say, really silly example, but 80 minutes, it's not correct to say that once you have removed wound dressing, that it's done. The patient is no longer exposed to anything, because the patient is still, the body of the patient is still metabolizing or still reacting to the contact with that medical device. And that's why we have changed the contact duration. And it's no longer something that you limit to the point of contact, but also that you have to consider longer. And that's why we went to daily contacts. So I hope that helps a little bit with the question behind it. And it's really, really all devices that benefit from this increased scrutiny, because it's something that was kind of incorrect in the previous methodology, to just think about the point of contact.
Okay, thank you, Elizabeth, for that answer. Before our next question, Walter, is there anything you'd like to add to this answer? Any thoughts or comments?
Nope.
Okay, then. Great. So I'll move on to our next question. And also a quick reminder to our audience, because I think I didn't mention this earlier. From this point, when you send in questions, please include the name of the presenter you would like me to ask your question to. Okay, great. So this next question to Walter says, from the slides about extraction ratio, you mentioned that adding filler material can increase the extraction ratio. Why would you not always do this?
So adding a filler material will increase your extraction ratio. So in this case, you will also start to kind of get a more saturated extract because you use less volume for the same amount of material. And in this case, sometimes you will then have to, your exhaustive point will lie much further because you're saturating your extract in the first cycles. So it takes much longer, and then you have much more cycles to do. So this is also less, it's not good. And additionally to that, adding other material can sometimes introduce also contaminants, and it's something to be really careful with. It's not always beneficial.
Okay, great. Thank you then, Walter. Any thoughts or comments, Elizabeth, before our next question?
No.
Okay. So our next question to Elizabeth then says, when do we need to be compliant to the new ISO 10993-1?
Yeah, good question. I see that there was another question that is really close to that one, which is, do we know if it is the regulatory geographies expectations to adopt ISO 10993-1 now, or do we wait on all guidances projects to be released? So I will answer the two questions in one go. So actually, there are some agencies that are requiring already to use the new dash one. So PMDA, for example, is one. So the Japanese authorities. Within Europe or close to it, I would say the MHRA. So for Britain, has mentioned apparently that they will enforce a 2 years transition period before using ISO 10993-1. But for the rest of the world, meaning the rest of Europe, there is nothing that is said at this point that ISO 10993-1 should be used or not be used. So technically, it means that it's published, it's state of the art, so it needs to be used. I do want to say that I would encourage you to reach out to your notified bodies, have discussions with them to understand what version of the standard they want you to use, because some of them are also involved in working groups. So we're presenting the development of ISO 10993-1. And so there are some of them that are aware that the project or that the standard itself is not is published, but there are other guidances that are pending, and so they might accept you to use the version 2018 still. So I really would encourage you to reach out to the authorities. For the FDA, there it's a bit clearer. There is nothing that was published yet as far as recognition go for FDA. So that means that they do not recognize the standard as of now. We do expect a kind of partial recognition, so not a full recognition. And so at this stage, my recommendation, if you are going to the US market, is to still use ISO 10993-1 2018 and the FDA guidance on the use of ISO 10993-1. But what we have been doing for now for FDA submissions is, because FDA will one day recognize the documents, even if it's not for now, not tomorrow, perhaps a few more months, and then a guidance document will come in years. It will take time. But my recommendation is to use the guidance document of the FDA, but also to apply some of the concepts from the 2025 version. And by that, I mean everything that is about the contact duration and the contact types, so that you're really using the new categorization system of ISO 10993-1 2025, because that's a bit worst case in terms of biological effects for consideration as compared to version 2018. And that way, if the FDA ends up partially recognizing ISO 10993-1, we do expect that they will recognize the categorization system. That way, you are still already thinking a bit ahead in terms of the categorization. So that was a long answer, but I hope it helps.
Okay, thank you, Elizabeth. Walter, are you happy with that answer or anything to add before our next question?
No, it was perfect.
Good. All right then. So this next question to Walter says, can we say that UF equals 1 is a worst case?
No, UF of 1 would be a best case. The worst case that we use is 10, because the uncertainty factor is below the bracket, the line. So it's as the higher the uncertainty factor, the more uncertainty that you'll have. So this is the worst case. And I think it's mentioned in the FDA draft guidance that if you don't know your uncertainty factor, you have to use 10
Okay.
for LCMS. But, yeah.
Okay, then. Thank you for that answer. Then, are we happy to move on to our next question, Elizabeth? Anything to add here?
No.
Okay. So our next question then, just pick one out to Elizabeth. Was a okay, this one. So the reasoning for daily contacts is odd, as its rationale doesn't extend past the last moment of contact. Beyond that, it takes into its position that we must be considered is the presence of the remnant in the body. But that depends on many other factors such as metabolism, ability to clean, contact surface swiftly, etc. Must or can that reasoning be included in the BEP leading to the classification/calculation?
I'm reading it at the same time because it was a long question. So just
Yeah,
allow me for a few
of
seconds
course.
to read it, and then
Yeah.
I'll get into the question. Yeah, so no, there is no reasoning to be included in the BP. My point was more to explain where the daily contact reasoning came up from. So really, there is actually no way to get out of it. Everything is considered now as a daily contact. There are examples within ISO 103-1 about devices and how they would be classified under the update of the document. There is no need to include a justification or an explanation about using the daily contact concept. It's really the base right now, how it should be considered. I do have to say, I mentioned the intermittent contacts. I do have to say, even if it's a bit beyond the question, that everything is daily contact, even with intermittent contact. But so devices right now can be limited and go up, be up categorized in terms of duration and be considered, for example, prolonged or even long term. But there will be additional guidance coming for bioaccumulation and intermittent contact. But all that to say that for intermittent contacting devices, if there is enough time between each of those exposure, because that's what intermittent contact is, 24 hours between each of the contacts. If there is sufficient time between each of the contacts, then there could be a way to say that we reset the exposure, because the body of the patient will then have the time, sufficient time to have metabolized or acted on all of those the substances of the medical device. So more on that, or concretely how that will be, that's really being discussed right now within the project group of the intermittent contact. But I did want to say here already that it's true that a lot of devices are up categorized, but for some devices like the intermittent contacting ones, there will be a kind of way to look into more than just daily contact, and perhaps think about resetting the exposure for each of the contacts, and therefore not consider or say that the device is long term, but perhaps prolonged.
Okay, thank you for that answer, Elizabeth.
Thank you.
Okay, so we'll go on to our next question. I'm just picked one out now for Walter. And this one says, where do the 288H for EU extractions come from? Why is that considered sufficient?
And that was one of the last slides. So it's in the EU we've seen it is less of a problem if you do a one-step extraction, and the 288 hours is because we had 4 extractions taking up 72 hours each. If you combine that together, it's 288 hours. And it's sufficient in the EU, only in the US up until now. Cannot say that it's going to be the case always, but up until now, we've seen that it's not an issue that you do a one long extraction.
Okay. Thank you then, Walter, for that answer. Elizabeth, anything you'd like to add here before our next question?
No, that's good.
Okay then. Thank you then. And this next question to Elizabeth says, isn't there a gap between the source of harm relevant to intended use and the adverse biological effect of a medical device? Does that adverse biological effect belong to the hazard or the harm? Can it be identified separately from a harm?
Okay. Yeah. So for me, that question is really it's important to look back into the definitions. So I would say that a biological effect is really the observable effect that we are seeing on a body or an organism after the contact with the medical device. So for me, a hazard is the source of a harm, and a biological effect or a hazard is a potential source of a harm. And the biological effect for me is something that we evaluate for medical devices with an idea that we are looking at potential for a medical device to have the biological effect on the body of the patient. So for me, I would say that biological effect belongs more to the hazard than to the harm, because we are questioning really the potential for that effect to really happen in the body of the patients.
Okay. Thank you for that answer, Elizabeth. Walter, anything you'd like to add here? Any thoughts or comments before the next question?
Nope.
Okay, great. Thank you then. And this next question to Walter says, concentration of the extracts means higher AET, but at the same time it poses risks such as loss of analyte. How do you account for these effects?
Yeah, for sure. For VOCs, so volatile organic compounds, you cannot concentrate because you will lose them all. So that's not an option at all. For the other techniques, so semi-volatiles and non-volatiles, yeah, what we do is we add internal standards for, it's called ISM for the method, and these are compounds that are added to the sample prior to this concentration, and you follow them up during your sample preparation. At the end, you check what their recoveries are and see whether the sample preparation was, if there's a lot of loss of them. But yeah, for VOCs, you cannot concentrate because you would lose most of them. Yeah.
Okay, thank you for that answer then, Walter. And we'll move on to our next question, unless Elizabeth, was there anything you wanted to add very quickly?
No, it was a good answer.
Good. Okay then. So this next question to Elizabeth then says, it is almost often possible that, like in your examples, MDs are used on a different possible population and time of application. If that means that you cannot declare a device for adults only or only for a short time, if that is no longer possible, then all devices need to be tested as if they are permanent pediatric devices, which seems impracticable.
Yeah, that's a good question. Thank you for asking it. So I think it's really important to understand that there is the theory and the practice. And by that, I mean that if you include in your IFU, for example, that your device is to be used 30 days, but that you get feedback from post-market surveillance data or from usability reports that your device is used longer than that, that's typically the reason why this misuse or this consideration was added into ISO 103-1, because there was sometimes a bit of a discrepancy between what is written in the IFU and what is really performed, and how often it is done that way. In those situations, then if you're aware that your device is always used longer than expected, then I would encourage you to upgrade the categorization, the contact categorization of your device. But then the other way around, I would also encourage you to not go over conservative as well. So if you're not aware that your device is, or if the situation is really where that the device is used longer than prescribed, then in that situation, I would not encourage for a longer categorization. Now, in terms of population, it's exactly the same answer. It's really a situation of looking at what makes sense for your device, and you can be unaware of a situation at your biological evaluation plan or biological evaluation reports stage, and then becoming aware of it with your post-market surveillance data afterwards. But as I mentioned, it's really a lifecycle evaluation, which means that you get a new data point that you include, that you feed in the next versions of your BP and DVR. So really, it's a question of what makes sense for the device, for the patient, and use all the information that you have on the field to know if this is really something that happens to your device, or if it's just overly conservative.
Okay, thank you very much for that answer, Elizabeth. So our next question will go to Walter, and it says, when concentrating the extracts, the formation of precipitates is to be expected. How do you deal with the precipitates that form during the concentration of the extracts?
Yeah, it's not necessarily expected that that we get precipitation, but yeah, I can understand that. Yeah, sometimes this does happen with the concentration, and then we treat it the same as I showed in the presentation with turbid extracts, etc. You need to, well, what you can do is, for example, check if it's possible to still inject this, but if it's only precipitation, yeah, then it's already becoming difficult, and then maybe you need to look at your extraction. Maybe we increase the extraction ratios so that the concentration factor needs to be less. But yeah, sometimes it's really searching for a solution, and it's not easy to find something. It's possible that if you get this precipitation, that maybe the solvent is not suited for these extractables, because there's something going on in this solvent.
Okay, thank you very much, Martin. So our next question goes to Elizabeth. And it says, is there a threshold above which bioaccumulation must be considered? For example, if a supplier only confirms that no bioaccumulative substances are present at a concentration greater than 0.1%, does this require chemical testing for bioaccumulating substances?
Very good question. Thank you. To the first part of the question, which is there a threshold above which bioaccumulation must be considered? The short answer is no. There's nothing right now in ISO 103-1 that says that mentions a threshold. I don't think at this stage, from what I have seen right now, I don't think that there is an idea of a threshold, but I might be mistaken. from what I understood on what is going on right now with this project on bioaccumulator, the bioaccumulation concept, and the project that will be combined with intermittent contact. In that project, the idea to address bioaccumulation is to look at how bioavailable a substance is. So you really do a material review of all of the materials inside your medical device, and you look if they can be made bioavailable. And based on that, there will be some kind of information provided in the technical report or technical specification that will indicate how much time needs to occur between each of the contacts in order to say that there is a potential for bioaccumulation, or if there is sufficient time to say that all the substances that are considered bioaccumulating are digested, metabolized, as you want to say it, and therefore will have been gone from the body of the patient before a new contact with the device is occurring. So at this stage, it's all that I can say. I know I'm not entirely answering the question, but I do have to say that there will be guidance. Today there is none, and we address this as we can. But yeah, later on there will be more guidances about this.
Okay, thank you very much for that answer, Elizabeth. So this next question to Walter says, why is the extraction volume defined based on the 3 centimeters squared / ml extraction ratio as required from ISO 10993/12? Is it mandatory to comply with this ratio for extractable and leachable studies?
No, it's just the starting point, and yeah, it depends also on what the device is. The 3 squared centimeters per milliliter are based on a thickness of your device larger than 0.5 millimeter. If it's lower, it's very thin device. Then it needs to be 6 squared centimeters per milliliter, and then also other shaped devices. Then it's given in grams per milliliter, but yeah, it's a starting point. If you have a difficulty in your extractable study because of the extraction ratio, then you can change it, because that's an easy argument to change the extraction ratio. It's not set in stone, and it's not a rule. And then the FDA even mentions this in their draft guidance that it's allowed to deviate from this starting point.
Okay, thank you, Walter. So this next question to Elizabeth says, looks like a lot of information is required to finalize a biological evaluation plan document. Does this mean you perform E&L before writing your BEP?
Thank you for this question. I do think it's a good question, because it's right, it's correct to say that there are a lot of information that are now required at the biological evaluation plan, so BP level. So to my eyes, the idea is still to write your biological evaluation plan, really define the strategy to address the risks of for the patient into that document, so into the BP. And the BP will define if ENL, so extractables, leachables, or chemical characterization is required for your medical device. And if yes, that's where the BP will stop. It will say, here is a plan, here is how you will address the risk for your patient. Then you go into the testing, and then the third phase will be to conclude all and summarize all results, all test results, including the ENL, into your your BER. So for me, the ENL feeds the reports of the ENL feeds in your BER. But as I mentioned, it's still a life cycle evaluation, so there could be results from your extractables and leachables data that are going to trigger something additional risks considerations. For example, you didn't know that there was a bioaccumulative substance in your device, and now from the ENL information you're now discovering that there is. Yeah, that's life cycle approach. It means that you go back to your BEP afterwards and you adjust accordingly. So for me, it's really you start with BEP, you do the tests or your risk assessments, you do your BER, but then you start again depending on what you find in your testing.
Okay, thank you for that answer, Elizabeth. So this next question to Walter says, do you need to see particulates or device degradation to define it as a destructive swelling? It is significant or severe swelling without observation of particulate or device degradation considered as destructive swelling?
Yeah, that's of course the difficult question. When do you talk about destructive swelling? Swelling in itself does not really change your extractable profile. It's when that's solvent or when the material starts to degrade. So putting a number on its the surface increased X amount of time or the size increased, it's difficult to put a pointer. And yeah, if it just swells and the extract is pretty clear or there's nothing much going on with the extract, I would not see this as severe swelling because this would not be enough argument to say that it's not compatible. It's when the device starts to degrade, and sometimes you don't see this in the extract, you only see this in the chromatography at the end when you see, okay, my extract is filled with material and it's just coming from my polymer backbone. It's just a polymer. I see a lot of oligomers just everywhere, and yeah, in that case, you can still do your TRA and try to say these components coming from my material are not really relevant. But yeah, to come back to the question, swelling in itself is, and especially with the FDA, it's not seen as if it's only swelling, it's not seen as a destructive swelling. Talking about destructive, it really you need to see the item changing quite a bit, like tears or other things happening, like breaking apart. Yeah.
Okay, thank you then, Walter, for that answer. So our next question, I think, is another one for Walter. So it says, polar and non-polar solvents are suitable for a hydrogel. For semi-polar, no solvent is suitable after visual inspection. Are only the use of polar and non-polar solvent together with rationale regarding semi-polar sufficient?
Kind of. It depends. Yeah, it depends a bit first where you want to submit. In the EU, I would say yes. In the US, I would say be cautious, because the question is also what did you exactly test? If it was just swelling, if it was a bit of turbid extract, it's not necessary enough evidence to say there is no semipolar solvent that we can use to extract our or to get a semipolar extraction. What you can do is pick the one that looks the best, I say, and try to analyze it. Of course, if it's very turbid, etc., you need to, for example, what we do is dilute it very large and then inject it to see whether it is really filled with a lot of unwanted extractable, or not even extractables anymore, it's degradation material. What you also can do is try to look for even another semipolar solvent and try to go to binary solvents. this in itself is also something that you need to be careful for. But yeah, in case of many degradations, or you get a solvent that is, it seems to be not not suitable for your material, what you can do is do this full feasibility study, check all the solvents, and then go to the FDA with a pre-sub where you say, this is what we did, this is what we tested, and this is how we would like to approach it with an extractable study, saying then, okay, we will not do a semi-polar solvent. And then you already have a plan, and the FDA will give feedback on that, and yeah, it's easier than to go forward. But yeah, in this case, especially with material that starts to degrade, it's this kind of approach is sometimes needed.
Okay, thank you very much for that answer. Okay, so we're almost at the end. We've got a couple of questions left before we finish, but we're going to try answer the remainder of Walter's questions we have here. And then very quickly, I have a question for Elizabeth. This question says, what are the expectations from regulatory agencies on ISO 10993 1 2025 to use it or to not?
Yeah, that's a question I already answered actually. But yeah, my recommendation would be to use it right now for Europe. But as I mentioned, don't forget to reach out to your notified body just to have a discussion with them about the standard, the version of the standard they want you to use. Some of them might be maybe open to wait on the additional guidances, depending ones, before you start using ISO 103-1. But that's really something that you want to discuss with them, and know that some other agencies are already asking you to go for it, to use the new version of the standard. And for the FDA, really, I do recommend to use the FDA guidance document on ISO 103-1, which is based on ISO 103-1 2018. But that's the one that they are agreeing with and recognizing. So to do that and to apply, as I mentioned earlier, perhaps the categorization concepts from the 2025 version, so that you are considering worst case in terms of categorization.
Okay, thank you very much for that answer. So this next question to Walter says, regarding testing pooled versus non-pooled samples for ENL, assuming 4 extract iterations to get to exhaustiveness, can you test the first iteration separately and then pool the remaining iterations? How would this potentially affect the AET? The reason for doing this would be to account for potential release kinetics.
Yeah, you cannot do either, like do the first one separately and then pull everything else. It's not going to be accepted. You need to test everything separately or pull everything together. So if you're interested in release kinetics, unfortunately, you will have to analyze everything separately also, because the moment that you start to pull subsets, it's difficult to say then where it come from. Is it the second cycle already that is low, or is it a very slow? I wouldn't do this. But it depends a bit also what you want to see and what you're interested in. I also saw a similar question about release kinetics. About the study setup, you can do this. We've done this before, where we just do, for example, it's degrading. The device degrades. It's designed to be degrading. What you can do is just like, for example, do a few cycles of 24 hours, 3 to 5, and see what happens with all your extractables. Other things that you might be able to do is, if it's something that degrades very fast, is to do a full degradation with time points in between. where you do it after, like, say, 24 hours, and then you do it after a few days, and then maybe 1 month. And yeah, this is also a possible setup for this.
Can I perhaps add something to
Yeah.
this? I do believe that this question might be related to release kinetics as of interest for the toxicological risk assessment. And I'm not aware of the specifics, but I did hear from one of my colleagues that that there was an amendment to ISO 103-17, and that apparently the amendment has made some restrictions about the kinetics. So in no case, before you jump into those kinds of considerations, I would encourage you to just check, because I'm not 100% sure, but I do recommend you to check this amendment to make sure that you can still do that for your risk assessments.
Okay, thank you, Elizabeth and Walter, for those answers then. So our next question is another one for Walter. It says, UF for GCMS mentioned in ISO 1099318. What about UF for LCMS?
I'm not entirely sure what the question or what is asked here, but so in part 18, amendment 1, there is given how to calculate the uncertainty factor, and each lab can do this. And at Nelson Labs, we have an extensive database which we generated ourselves for a lot of extractables and leachables. So we are able to calculate our own uncertainty factors, which is 2 for GCMS and 5 for LCMS for each ionization. For techniques or where it, for example, a lab that doesn't have this, you should use an uncertainty factor of 4 for GCMS and 10 for LCMS, because we've received this feedback before, and maybe it's mentioned in either the FDA draft guidance or some other document to use this. And 10 will be always the worst case. Yeah.
Okay, thank you for that answer. And then our last question for today's Q&A session, because we're coming up to the end of our time, I think is another one for Walter. It says, for dialysis solution, we have a very low AET. This situation is very difficult to meet AET.
Yes. So of course, dialysis solutions, it's a large volume that you will have as clinical exposure, and you will always have low AATs. And I hope the regulatory bodies understand this. And it depends also if you want to address this as a medical device or as a container closure system. If it's a PD solution or so with a PD solution and a large volume parenteral, then it's more a container closure system. But yeah, if it's classified as a medical device, the only thing that you can do in this case is to concentrate or to underfill. It depends a bit, yeah. But yeah, low AETs are of course something that happens with dialysis solutions, and yeah, everybody has this. It's not that you can do anything about it. It is what it is, and then you need to concentrate quite a bit. This is unfortunately the only solution.
Okay. Thank you for that answer then, Walter. And thank you to everyone who sent in their questions for Elizabeth and Walter in today's Q&A session. We had lots of questions. And I'd like to remind everybody that you can watch this webinar as a replay and other webinars by visiting our website, which is biopharmawebinars.com/webinars. And before we finish today, I'd like to go back to our presenters to ask them if they have any takeaway comments to leave us with. So Elizabeth, would you like to go first?
I would say, yeah, don't hesitate to reach out if you have any questions. I know the ISO 10993-1 update it's quite an extensive one. We will all be learning the process in the coming months, years. The biocompatibility assessors, the industry, the notified bodies, everybody. So it's a learning process. Don't be scared about it, and just reach out if you have questions. Little steps at a time, I would say.
Okay, great. Thank you, Elizabeth. And Walter, anything you'd like to leave us with?
Yes, I hope nobody fell asleep because it was so long. But yeah, in any case, what I wanted to do is to start or to just inform everyone of general things that can happen in extractables and leachable studies. And I'm sure everybody or a lot of people still have a lot of questions or concerns with studies that they want to do or studies that they have ongoing. And in any case, they can for sure contact me. And even if it's not for me, I can guide you to the correct person to answer your questions or to help you with that. So yeah, feel free to reach out. Yeah.
Okay, thank you then. And I would also like to thank our presenters for joining us today. So once again, that was Elizabeth James, biocompatibility expert at Nelson Labs, and Walter Bisons, E&L project manager at Nelson Labs. So Elizabeth and Walter, thank you very much for today's webinar and Q&A session. It was a pleasure to have you both here, and we're all done. So I hope you have a great rest of your day, and everyone take care. Okay, bye-bye.
Thank you.
Bye-bye.
Goodbye.
Goodbye.